That's a challenge, my friend.
I know it is. And I know myself. I know how difficult it is getting primary care. I know how difficult it is when you're sitting in A&E. I've been through that myself. I know how difficult that is. But we've got to find a way to work through that. You're right. I mean, the Integrated Care Board, who leads the local system, the health and care system, is trying to set in the framework to make this work. Part of the reason for them transferring out responsibility for commissioning to us and people like us is because the view is you can do more collectively. You can cut through some of the bureaucracy. You can take decisions quicker. You can make sure the vast majority of the money goes where it's intended, which is out there to staff and to services. In many cases, it has taken longer than it should. And, you know, part of my role is to call that out. When there are difficulties, but you call it out in a sensible, mature way and try and get the best outcome. Not to have a go at someone, but really to say, look, we're all trying to achieve this. How do we achieve that? As opposed to, I want me 5p off you. This is about, how do we spend the Birmingham pound in a way that makes the most difference to Birmingham residents? It shouldn't be about organisations. It should be working outside of the barriers of your own organisation, causing the system to work, to make sure we work collectively for the residents of Birmingham and Solihull.
Absolutely. 0121 772 8892. You might want to join in this conversation. We're talking to Executive Director of Finance, Dave Tomlinson, and we're really getting into, we've got the gloves off really, talking about how we're moving forward around the situation. And I believe we did have a caller. Caller, if you're still listening, I'm sorry about that. The line went down for some reason. Can you give us a call back? And if I could ask the guys who are in the studio to just put that call through for us, I would really appreciate that. That would be really helpful if you could do us with that. I think, is he back now? Hello, caller, are you there?
Can you hear me?
Yeah, hi, caller, are you there?
Yeah, can you hear me?
I can hear you now. Yes, thank you. Thank you for calling.
Okay.
Who's calling, please?
This is Rudy Page.
Oh, thanks for calling, Rudy. Appreciate that. You've got a question for our finance director.
Yeah. One of the things that's of great interest, obviously, with such big system change, and we are now led to believe with these new commissioning arrangements that the local trust will have much more financial control over service provision. So it would be helpful to better understand how this is going to translate into an impact service design or redesign or reconfiguration of services, given all the evidence that we have, historical and systemic evidence around inequalities, health inequalities, I should just say, and the challenges with regards to improving how they're tackled, I guess. That's what I'm really saying.
Okay, that's a great question. Thank you for that. So we're talking about systems change and the new commissioning arrangements. How is that going to support not only patients but also improve health inequalities? Dave, great question, I think.
Yeah, so there's two or three parts now. It is a really good question, and I'll try and unpack it first. And I'm not trying to avoid the question at all, but just trying to unpack it. I'd want to talk about the health inequalities bit first, if I can. So we're very conscious as an organisation about health inequalities. It's something that's a real priority for us to do something about, to make sure that whoever you are and wherever you live in Birmingham and Solihull, you've got equal chance, you're equal access, all that type of stuff. We really take that seriously. So it's a real opportunity to do something about that, and we will keep that right at the core of everything. I think what's worth saying also is that just giving us power, commissioning authority, doesn't necessarily change anything. It's what you do with it. It's also the thing to be aware of. It doesn't mean to say there's new money. There is new money, but not as a result of us having it. And we're responsible on behalf of the system to make that work going through. You're absolutely right. The bit about transformation is we've got to do things fundamentally different. The argument, though, is by giving it to providers who understand how services work and how they work alongside others, you're more likely to get sensible outcomes that make a difference to patients out there, the people who use the services, because they touch, breathe it, they spend time with them all the time. They should have a far better understanding of what works and what doesn't. We've got the authority to work to make that system work, to really make that change, but it is difficult. If it was an easy thing, it would have been done years ago. This is incredibly difficult, but it's also a real opportunity. It's been already said earlier on. This is a real opportunity to change. We're absolutely committed to that, and people like you need to hold us to account. We've got to be able to describe exactly why it's different and exactly what we're doing that make a difference. We're doing something right now, so before the end of the year, we would understand what people are actually saying needs to change. People would say they've been consulted to death and that's loads of time and they want to see change. But we think it's really important to find out from the horse's mouth what really matters. We've also got to make sure it's not mental health in isolation over there, but it's mental health working alongside other services, working alongside primary care to understand how that entire system works. So I think I've said before, what you get right now is people, because they've got nowhere else, will go to A&E. They can't get into primary care. Primary care struggle to hold people with certain conditions because they haven't got the specialist, skills available. We've got to make sure that system works collectively to do exactly what you're talking about. So it should really be, how do we make sure that people get the service they need when they need it out there, rather than you've got to come into a big hospital, you've got to come into an inpatient stay. We need to avoid that. We need to move the locus of service and delivery to out there where people are. So in the local areas, it's about working alongside what's all called, there's a similar provider collaborative around the community area, community services that are going on alongside primary care, and we've got to work collectively with them rather than passing things between. We've got to try and manage and help that local cohort, that local set of people to get the service they need out there so they don't have to come into the centre.
Brilliant.
Now that's going to take an awful lot change to change it through, but it's really important people ask the question and keep pushing, because the danger is, I'll say that, and it's easy to say, delivering it is far more important. We've got to really do that.
Brilliant. Thanks,
Can
Dave.
quick
do you want to come back?
That,
you want to come back, Rudy? Yeah, sure.
Yeah, please. I guess I understand what you're saying, but I guess what I was also alluding to is some of the historic system challenges, and also would be the changing culture, because we haven't used that word co-production.
Yeah.
And these days there's a challenge around it being accepted by the workforce in terms of that co-production, because it's still very new to people within the system. There's a term we use that developed throughout COVID where we said the workforce is the community and the community is the workforce, because we had the challenges around trust and cooperation. So how is that culture change going to happen in a period of time the public will notice, and the acceptance of co-production as a way of working, as the business of normal, I guess that's what I'm really.
Yeah, thank you for that
asking.
second question. Great.
Yeah, it's a great question. And co-production, as I said before, the health inequalities, co-production is also something that we take really seriously. There's plenty of examples. I'm not the best person to talk about all the examples of co-production, but we're trying very much, when we set up this new commissioning part, we're not doing to the voluntary sector or the third sector, we're working alongside them. We're also working alongside service users to actually work this through. What we try and do in every case now, we'll co-produce with both staff and also service users, the people that get those services. And it's really important we stick to that and really take into account what people are saying. Not what we think, but what people are really saying, and understand that in a way. So co-production, there's a danger. You just tick the box and we do this and we say it. Well, you've got to really do it and mean it and stick to it over a period of time. I think the other part, the culture piece, absolutely right. So the last 2 or 3 years, this trust has really worked hard in terms of changing that tanker. It's been going in one direction for a long period of time, and we've really got to change it so it's easier to make change. It's easier for staff to get involved. It's easier for people to speak out and make a difference. You're absolutely right. Honestly, I really support what you've talked about there in terms of those things. We've got to do it and really make a difference, and it's got to be things that we try and get the rest of the system to also take seriously. People often talk about health inequalities and co-production very lightly, but they don't necessarily follow through. And we've got to do this on an ongoing basis, year after year after year after year. And we've got to make sure people like me really get it and explain themselves, go through in that way. As I said, I can't talk about all the details of everything we've done in that area. Others can. And it's probably something we need to come back on, or we need to explain fully. But absolutely, couldn't agree more with what you're talking about there.
Brilliant. And I'd like to take this time just to thank you, Rudy, for calling in the programme. And again, I think when we have our executive directors on in this kind of space, which is so interactive, so engaging, when people like yourself come on and ask specific questions, we get answers. And like Dave says, we've got to work harder to make this thing easier. As he said, it's a complex, sophisticated process, and it's going to take some time. So thank you for taking the time and also asking a couple of great questions. That was Rudy Page there. And Rudy, if you remind me, I'm sure you're from London, aren't you?
Yes, I am indeed, but spend a lot of time in Birmingham, of course.
Of course, brilliant.
For 40 years. That was always.
Brilliant. And I know that you know the NHS really well, so it's really important that as we together go forward, that we can really make some positive contributions to this dialogue. Thank you very much for joining us.
Thank you.
That was Rudy Page there calling us from London, and as you can see, the reach is really quite important in terms of how we do this work.